Okay, good afternoon, everybody, and welcome to this meeting of the East Riding's Health and Wellbeing Board. Can I have a thumbs up from people listening in on Zoom, just so I know you can hear me? Thank you very much. So welcome to everybody. And just before we start, you will probably have received an email from Michelle the other day notifying you that Fuluke will be leaving NHS England and NHS Improvement. And I don't think she's with us today, but I really would like to pass on the board's thanks for her efforts over the last 18 months or so as a member of this board. So hopefully she may be watching this or in the future. So our best wishes to you when you do leave, Fuluke. Thank you. So I'll move on then to declarations of interest. Has anybody got any particular declarations they'd like to make? Bearing in mind, obviously, as we go through the meeting, you can sort of chip in if you feel you have. Okay, then we'll move on to item 2, minutes, to approve the minutes from the meeting of the 27th of January 2022. Of those there, are you happy they're a true record?
Yeah, move it.
Thank you very much. And then we will move then on to item 3, changes to health and wellbeing terms of reference and membership. I'll pass over to Michelle to briefly go through some of the changes in a second, but obviously the background to this is very much tied in with moving towards the integrated care system in the months to come, and how the health and wellbeing boards, and particularly ours, will fit in as a sort of representative of place, etc. So a lot of these terms of references are being changed around that agenda that will be coming up in the future. But I'll hand over to Michelle now just to go through some of the changes with us. Thank you, Michelle. Thanks.
Hello. The Health and Care Bill introduced in Parliament last year confirmed the government's intentions to introduce statutory arrangements for integrated care systems from April this year. Therefore, CCGs will be abolished, and that was intended to happen this month. However, that's been delayed to July this year. And the CCG statutory functions will be transferred to the Humber Coast and Vale Partnership Board, which sits within the Humber Coast and Vale Integrated Care Systems. Therefore, our Health and Wellbeing Board remains the overall strategic body for progressing the health and wellbeing of its local population. However, the Health and Wellbeing Board is widening its membership to incorporate the disbanded East Riding Place Board, and it's also widening its membership to incorporate all of the existing networks and partnerships that are involved in progressing the health and wellbeing of the local population. So for these reasons, it necessitates a review of the Health and Wellbeing Board's membership as set out at Appendix 1 of this report. The proposal is that the Health and Wellbeing Board will comprise of 13 voting members. You will see in Appendix 1 that we've listed 12 voting members. However, this should also include someone from primary care. Unfortunately, this had been inadvertently admitted in this report, and we've approached our NHS colleagues for them to put forward the most suitable person who could hopefully represent all the primary care networks. In addition to our voting members, we also have 7 non-voting co-optees as listed in Appendix 1, and the board will also invite other necessary representation as and when it's appropriate to the meetings or the themes of that meeting. Therefore, the Health and Wellbeing Board will act as a place vehicle for determining the wider determinants of health. Thank you.
Thank you very much, Michelle, for that. Has anybody got any particular questions before we just talk a bit more widely about probably where the Health and Wellbeing Board is moving? I don't, particularly about the membership, because I know we've always over the years had various discussions about who should or should not be a voting member, how many people permanently come, how many people can be invited. And my view is it's probably going very much back to the old days of a more local strategic partnership type approach with, you know, other people in the voluntary sector, maybe police and fire at times attending, depending on the issues. So, you know, it's very much going full circle to where we probably were a few years ago, but in a different way. And I think what I will do is, if I can pass over to Caroline, our Chief Executive, Caroline Lacey, just to give me her take on how she thinks things moving forward, then I'll go around those with questions. Thank you.
Thank you, Chair.
as Michelle said, really, that this board is now taking over from what was an officer-led sort of East Riding Place board, and as Councillor Owen says, it really is going back to perhaps where we were a few years ago around the local strategic partnership, really recognising that, you know, health and well-being is not just about the health system. It relies probably 80% on those wider determinants of health, such as education, housing, having a good job, all of those things that impact really. And I think as part of this, you know, we've alluded to that in the terms of reference. We will be bringing other existing networks such as the Community Safety Partnership reporting in around, you know, how safe does our community feel, and other bodies as we need to bring in. I think one of the conversations for today was around what do those wider terms of reference look like. So it's not only about improving the health and well-being of people in our area. And if we look back to the previous community plan, there was some really broad objectives around children and young people being happy, healthy, confident and safe, reaching their potential, that older people enjoy that healthy, independent lifestyle. We had an objective around communities being thriving and prosperous and safe, that regeneration transformed deprived areas, and that the natural environment was protected, and then we had sustainable economic growth. So I think it's, whilst they were at a point, and no doubt we'd want to recognise things like climate change and zero carbon, etc., it is trying to look at those broader objectives that we might have, where we can bring in people to this meeting to make sure that we're on track to ensure that we do truly improve the health and well-being of people in the area, but not just from a health point of view, from that wider point of view.
Yes, thanks, Caroline. And I think it's also much more important moving forward when we have sort of our representation on the ICPs in the new system, you know, because that'll be the place where all the places of sort of Humber Coast and Vale will actually be together reporting into the ICB. So I think it's, you know, that wider remit is going to be important if we want to hang on to those tenets of health improvement and prevention, rather than just, you know, what I would cynically say traditionally has been sort of keeping the acute hospitals going. So, you know, that'll be our voice to hopefully prevent that happening. Councillor Harold, you must come in. Thanks.
Thank you. It's really on what Caroline has just said, in fairness. My thoughts when I was reading the papers around the membership was, it is exactly who you would have always assumed would have been here. But I wondered whether my question would be, when we're looking at the health determinants in the wider sense, and we're looking at the economic regeneration and growth and housing in particular, that is a major priority. And yet we don't have directors sitting on the board that have the responsibility for that. So whilst it's okay, I suppose you could argue that you can bring them in as and when you need them, it isn't actually, they aren't seeing the wider context and the wider narrative around it. So I suppose the question would be, whilst we have, you know, the directors that are here, that's great, and they obviously have a vested interest, but actually I would have liked to see that broaden in some sense to include those that, you know, the economics of an area is a massive determinant of health, as is housing, and they're not on this board. So I suppose if they aren't going to be on it, then I think we need a really robust plan on how we link them in, and not just popping in every now and again. I think they need to be part of that conversation.
Thanks, Councillor Harold. I think in response to that, we have, you know, on the board now the Chief Executive, I think, that will carry out some of that responsibility, and we've brought on as co-optees representatives Pickering and Ferrens Homes to cover that sort of housing side of the issues, I think. But so, yeah. Sorry, Andy, I'll come to you at that point. Thanks.
Thank you, Chair. Apologies, my voice goes in the middle. Can you hear me okay? Sorry.
We can hear you.
Good.
Fine, thanks, Andy.
I completely agree with both what Councillor Harold said and what Caroline said, Chief Exec said, in terms of, but I think we need to go further in terms of pushing what the board can do. in that rather than being a passive receiver of reports, listening to people talk about what their plans were, operational plans, I think it needs to have more of a dynamic push and pull role, in that it sort of stimulates strategy. I think the discussion about going back to strategic partnerships is that it's someone who's constantly gardening the strategies, seeing where they're at, seeing where they're not working, rather than just going down operational routes. So the broader point I'm trying to make is that if health and well-being, 80% of it is employment, education, housing, environment, the conditions of living that shape people in order to be able to become resilient and shape communities, then I think the Health and Wellbeing Board can stimulate questions about it. So it can ask questions, it can inquire, and in terms of the system overlap. So rather than focusing particularly on, for example, on a hospital reconfiguration, whatever, but it can focus on the overlap between children's mental health, between what they may be seeing in the health service, what they may be picking up in schools, and what they may be seeing in community. And I think it's that system picture is where the Health and Wellbeing Board adds the extra benefit, because it brings everyone together. And the membership of the group, I think having, once every X months, everyone together would be difficult. But if outside of it, we could be stimulating those networks, whether it be children, whether it be adults, whether it be environment, whether it be hospital reconfiguration, and then it being that appreciative inquiry, that strategic inquiry that this board generates on an ongoing basis. So it's constantly farming the networks outside by pushing the questions in, pulling the issues out. And it's that sort of gardening approach, rather than just looking at what's going on once every couple of months. It's actively, the board is an almost ongoing conference. It's actively pushing, questioning, taking information in, pushing information out. And I think that's where, for example, the JSNA, the Joint Strategic Need Assessment, rather than being a one single document that sits on the shelf, is more of this dynamic. It's constantly asking the question, and whether that's from individuals in terms of their lived experience and how that shines a light on access or community tensions. And in the same way, it's taking the big performance information together. So I think it's a mixture of, I'd expand the aspirations of the board to be this more dynamic gardener of the health and care system. It's actively out there, looking, probing, pushing, turning the soil to see what's underneath. And I think that's the approach I think would allow us not to be reliant upon having a giant room of people to answer questions, because we just never have enough time. I think we need to do it through the networks. Apologies if that was a little bit garbled. I'm actually, I have covered at the moment, so my lived experience, I'm going through what many of our residents have gone through, so I'm trying to make sense of it. But that's my overall point. The Health and Wellbeing Board as a gardener of the health and wellbeing system.
Thanks, Andy. We're going to have to find a bigger potting shed to meet in, I think, in months to come, if that's the case. But yeah, thanks. I'll come to Councillor Evison and then Paula. Thanks, Jay.
Thank you. It's exactly along the same lines as Andy was just saying. I'm quite comfortable with the people that we invite to sit around the board, on the table, and I feel quite comfortable that we know who needs to be here and how we achieve it. What I'm more interested in is what we actually achieve, and that people that come to this meeting go away with the view that they're going to make a change, not just sit around and discuss things and the health and well-being of residents in the East Riding, but very much that about the aim of this board and the members of it, in that they take away the information, or we arrive at some recommendations about things that need to be done, and actually take that work away and do it instead of just discussing it. And that concerns me more than our discussion about the representatives, who I think we all know who needs to be here, and I'm quite comfortable with that. It's more about our vision and our aim about what we need to achieve and how we do it.
I'd also throw out the challenge that the reason we have sort of 5 portfolio holders on the board is to champion some of those causes as well, rather than having to have directors alongside them sort of moving forward as well. Yeah, Paula, thanks.
Thank you, Chair. I think I'm just going to echo the sentiments of Councillor Evison and Andy around support their position, really. it's I love the idea of the garden and particularly of this sort of dynamic approach that Andy's setting out in relation to how we will do our work here in the Health and Wellbeing Board. And I guess just to add to that, in my feeling, my position is that if it's indeed possible, it's even more important in our new set of arrangements as we move to integrated care than it is in our current set of arrangements. It's going to be a key anchor, I believe, for place, the glue that will hold us together. And it's important that we get both the work that we do right here and the membership, bearing in mind that we will lose a lot of sort of the statutory nature of CCGs. That's not going to be replaced place. You know, that will be, will not have a you know, a sort of a statutory basis, and so our key anchor will be, in my view, Health and Wellbeing Board. So just wanted to set that out in terms of the absolute importance of this board. It will be paramount in my view. Forward.
Thanks, Paula. Claire, you had your hand up and it disappeared again. Did you want to come in?
I did. Thank you, Chair. I don't know where it went to, but thank you for letting me come in. Just to say hello as a relatively new member of the board, but also as an identified housing representative. And the point that I wanted to make is that previous to today's meeting, particularly in Councillor Walker's chairmanship, that there was some really useful workshop events where a much broader church of people were able to discuss some of the issues about kind of the broader elements of health and well-being. And I think that's where particularly I can see wider contributions coming into play by the formal governance taking that out into a wider network and workshopping issues so that they can be brought back in a much more cohesive sense into the board for decision making. So I just wanted to put that point forward.
Thanks, Claire. I think that's something we would want to do in a controlled way over the months to come, because what I don't want to, I know I was harping back to days of the old local strategic partnerships. I certainly don't want it to be the same model as it used to be in those days, you know, of just reports coming to a board that met every few weeks and everybody went away again. It, as Andy says, more dynamic, more challenging, and probably wider discussions rather than just a set list of topics every time we come here. So yeah, thanks. Points well made, I think. Councillor Harold, again. Thanks.
Thank you. No, that has really reassured me, because I think I'm only a new member on the Health and Wellbeing Board, so this is my first year, and I think what is worrying me is that we have to get this narrative through to everybody, that it isn't just health that have the ability to improve the health and well-being of our residents. So I think what I've listened to and what I've heard has really reassured me, and I do think now that as long as things are done in the background, then absolutely fine. But I suppose just the caveat to that is we do really need to ensure that, you know, this does get through to some of the other areas, so asset strategy, economic development planning for those areas, because they are the ones that sometimes hold the key. And if they're not talking about it now, it's not going to be happening in 5 years. It's going to be happening in 10, 15. So I think there's just a little bit of urgency around, you know, that message getting out to them that health is their issue as well. It is their concern. But that's great. I'm really reassured of everything I've heard. Thank you.
Thanks, Councillor Harold. I think, sorry. Andy, again, thank you.
Thank you, Chair. If I could just add one thing as well about how we frame the problem and what we're looking at. And in the past, I think we've looked at health and social care as almost like an engine in terms of different parts related. And if we can line up operational plans, it'll make things work. And I think that hasn't succeeded. And that we need to look at it as a complex adaptive system, complex in that all the parts are interrelated, and something happens in one and something strange happens in another, and it's not predictable. And I think that's the issue where the board actually helps as well, in that it can see, because it's got this feedback loop thing going on, it can work out when things aren't working. So for example, workforce, one area increases pay in one area, it causes a crash in service availability in another because you can't employ any staff. Similarly, flow through hospitals or social care or in education, either way, it has an impact that's either immediately impacts upon and causes a crisis in another section. And I think that, again, that's where the board, if we were looking at all the different strategies and how the strategies are being created, that we can have an influence on that. So if we're looking at what the good life, for example, would be in Withensea, and focusing on the individual rather than services, you could immediately see when a problem was happening. So, for example, transport availability would become a top issue straight away. So I think what the board can do is, if it shifts from a focus on operational plans to broader system and where the overlap impacts on individuals in their communities, and creates a feedback loop from individual stories, from what's on the top of the mind of managers working in those communities, and what the local suggestions might be, the strong bits that we can build upon. I think the board could have a real transformational rather than transactional approach to systems. It could be the ones that's tinkering with the areas, because it's creating a common vision of what it's like to live in a place and what the good life would be in that place, where health, education, housing all fit for individuals and families. So I think in the past we may have not looked. We've not understood the complexity of a complex adaptive system, and we've focused on managerial solutions, I think. And I think the NHS have done similarly, and that's when it was split apart with competition. It meant that it was very difficult for everyone to work closely together. Now, providers are collaborating, commissioners are working closely in planning. We're obviously working a lot more closely now than ever before. And I think the opportunity is there. And what I've been picking up from ICS colleagues, CCG colleagues, is this opportunity, this awareness of the complexity of the problem and a willingness to try new solutions. And I don't think we've had that before. And I just feel now as if we've got an opportunity, and the board really needs to grab that, I think.
I think as well, Andy, that there'll be another 5 partners in the ICS on similar lines to us now, which is a big difference from where we were before. Although maybe the main players, the acute hospitals, are the same, it's bringing them on board into this much wider system as we move forward as well. So that'll be an interesting challenge, I think. I'm just wondering at this stage, that the paper was about new terms of reference, which tend to be the statutory minimum at the moment, which I'm sure in the light of discussion we've just been having can be built upon in the months to come. But I think at this point in time, it would be nice just to agree that core membership of the new board, which again, I'm sure can change with time. But are we collectively comfortable with the terms of reference they're set, which can change, but certainly the initial composition of the board? Can we agree that before we move on maybe to discussion what our joint priorities are at the moment? Are we comfortable with that? Okay, thanks very much for that then. We thought under this item as well, it might be nice, without putting everybody on the spot, but just to highlight what some of the joint, issues and challenges are at the moment to people. And I might turn to Caroline to kick off. Sorry to put you on the spot, but I'm sure a lot of it from our point of view is around workforce and accessibility, etc., etc. So Caroline, would you like to maybe kick off a little debate on this?
Thank you. So obviously we have a set of council priorities that are published in our business plan, and we can look at business plans of partners as well to draw those priorities now as they're around children and people, helping them to achieve, supporting the vulnerable, empowering communities, particularly to be more resilient and develop, growing the economy and around our environment. Underneath those, we've got a set of key actions that you would expect around climate change, zero carbon, investing, etc. And we'll share our sort of core priorities with partners and collect partners' core priorities. I think underpinning all of those, though, we've got some significant issues at the moment. Workforce is a key issue, and I know we've discussed in the East Riding Health and Care Board how actually, for once in our lives, it's not particularly funding that's the determining factor. It is actually workforce that's the determining factor, and that is going across, I think, virtually every partner that we talk to. Workforce is one of our biggest challenges at the moment, and one that certainly from the East Riding Health and Care Board earlier this week, we thought that we ought to do some joint work really across the piece, and perhaps with colleagues in Hull, recognising the travel to work patterns of a lot of our a lot of our residents really and our workforce. So that's a key area for us. Obviously, we've got key issues around supporting our children and young people, particularly with the sort of Ofsted improvement agenda, and the SEND agenda is a big issue for us. And as we're looking forward and wider, it's around devolution and what powers and funding can we ask for from central government as we work towards a county deal that we don't perhaps have now, that would be key levers really in helping us with those wider determinants of health, particularly around economy, skills, transportation, etc. So I'll leave it there to leave other people a chance to come in and say something else.
Just wondering if anybody else would like to contribute as to what of their key pressures are that may be different from some of the ones that Caroline's outlined. Anybody like to volunteer anything? Or
I'm happy to chair. So it's Michelle. I've turned my camera off.
Thanks, Michelle. Yeah, go on. Yeah.
I will try and put it back on, but I'm having some broadband problems, so I'll leave it off. So hopefully everybody can remember what I look like. Oh, I'm there. Can you hear me? Okay. Just sort of echo what Caroline was saying. We've got a lot of innovation and development going in spite of the sort of the positions that we find ourselves in, obviously with the pandemic. We've still got high levels of COVID, both from a staffing point of view as well as from a service user patient point of view across the organisation, and demand continues to be absolutely massive and exceeding our trajectories that we did, because if you remember, demand was picking up prior to COVID, and then obviously in patches and obviously since, but it is continuing to rise across, but also the acuity aspect. Now, whether that's due to rising poverty, rising health inequalities gap, or just due to some service provision and accessibility of GPs, etc., or whether it is just genuine acuity, people are seeking care later. So we've got to look at that. So we're looking at how we can sort of end that curve for people coming into the services a lot sooner, because that creates its own problems as well. So the acuity remains really problematic. I suppose the two areas that are really concerning is older people, particularly around, if we're looking at East Riding, that's particularly, we've opened some of our beds, we've built some more capacity into the system, but we're still having quite a lot of issues. It's not about beds, we know that we've got a lot of community provision, but we, again, because the acuity, we did need that assessment position. And obviously children and young people. Now, some of the work that we've done in relationship to East Riding has proved to be really helpful with the schools and the links in with the schools and the wider system, but we are still continuing to have an increase in position in relationship to waiting for children and young people services, and a lot around eating disorders, which I know is national, and we know we're doing some national work, and I'm linking into some of the national work for that as well, but we have got specific eating disorder and disordered eating issues, and reflective in East Riding as well. So we're just looking to see how we can increase that community provision in the main, because it's more important from a community point of view. And I suppose surrounding all that is our workforce. As Caroline said, we've still got a massive workforce issues. We're actually quite fortunate, I'm going to say this out loud, that we do recruit quite well as an organisation, but it still gives us massive gaps in the system. We are growing our own, so we're using apprenticeships, we're trying to be an anchor organisation, and doing lots of different things around certification. We've got a lot now of international nurses within our fourth cohort now from that, because we've just been so many across it in stages, but the workforce continues to be a major problem, but they continue to be amazing and doing an amazing job. But the workforce continues to be the biggest issue, and then obviously trying to work within a system that's changing as well makes it more complex at a time that it's complex. But I'll stop there. I could carry on for a long time, but hopefully that gives you a bit of an overview, Chair. Lots of positive things happening as well. Sometimes we forget the positive things that are happening and concentrate sometimes on the negatives, but that's what I started with. Lots of innovation in the system. We're trying a lot of our transformation work, but that is on the back of lots of other service pressures, and that includes primary care, particularly in East Riding. We've got some real hotspots in relationship to primary care in the East Riding. But again, I'll stop there, Chair.
Thanks, Michelle. I'll bring in Paula now, then Emma, then Jackie. So Paula, thanks.
Thank you, Chair. I agree with everything that Michelle and Caroline has said, and I won't repeat that. But I guess so. What I would like to add to this discussion is for me, it's a combination of having to do as Caroline and Michelle have said, is actually to address the high case level of COVID at the moment, which is causing problems in relation to staffing absences particularly, and do our elective recovery work. So that's for people who have waited a long time on the waiting list from about phase 1 of COVID, in terms of routine procedures that they require, as well as doing our non-elective work, so our urgent and emergency work, which of course is under immense pressure because of the high levels of COVID cases at the moment, the workforce pressures that both Caroline and Michelle have talked about. And so that sort of combination of having to do all those together, I think, is causing real pressure in both the health and care system. And there isn't one particular organisation or setting that I would pick on and say is more pressured than the next. They are all under tremendous pressure at the moment, and we're seeing that through. That's coming through in long waits in A&E, long ambulance waits, but that's a barometer really of how the system is functioning. And then, as Michelle said, we're trying to change. We're trying to architecturally change and move into integrated care arrangements. We're trying to, we're thinking very loud and long about actually what does that really mean, and ultimately, one of the cornerstones of that is health inequalities and how we do that, and particularly if we think about the NHS, about how we address health inequalities in terms of access and outcomes, alongside doing everything else that I've just described, is a real pressure at the moment, and probably as pressured as I've seen the system for some time. I can see that we will get out of this and through this, but at the moment there are significant pressures for the health and social care system in East Riding and in the rest of the Humber and wider and indeed nationally.
Thanks, Paula. Emma, I'll bring you in now. Thanks.
Thanks, Chair. Emma Dallingmore from Holland East Yorkshire Mind, for those that don't know me. I just wanted to give a voluntary sector sort of view on how it is for us as well, and it's exactly the same. We've got the same workforce issues as everybody else. Sometimes I feel that we have a bit of a smaller pond to fish in, so it can be even more difficult to get people. It's harder to make people stay as well. We're often seen as a stepping stone into something else. So that is quite difficult, and we're constantly trying to recruit. So we are looking at different ways in which we can do that. But something that we've noticed recently is that capacity has reduced, not because of staffing, but because we're going out more. So I love that we're connecting with people. I'm loving that we can go and see people, but that travel time in between means that we can see less people in a day as well. So that does have an effect on the people that we can see, the amount of people we can see. And I think we need to be mindful of that, because we were able to up that during COVID, and that has changed. I think something that's really good as well is that as voluntary sector is now much more part of the discussion, we're becoming more integrated, so we have more of a say about what's going on. We're a part of the innovation with the NHS and with the local authorities, and that's really important and exciting. And I think that's where the change is going to come about if we keep strengthening these relationships.
Yeah, thanks very much, Emma, for that. And certainly, all this work with the voluntary sector is something I think we want to really build on moving forward. We've been saying it for years, but it is a strength now, and I think those connections are going to be improving as time goes on. So, Jackie, I can bring you in now. Thanks.
Thank you, Chair. I agree with everybody else's opinions as well, and particularly Michelle's. And as a community provider, we are seeing very similar issues, and our biggest issue at the moment is workforce. We've got a number of our services going into business continuity, dipping in and out of business continuity. At the moment, we've seen a massive peak in COVID absence amongst our workforce. And recruitment, we do recruit, but it's the retention as well that we are working on, and we've been out to international recruitment and recruited successfully, and we will be doing so again, because we are all fishing from the same pond, and we use that term all of the time, don't we? We are doing lots of fantastic developments, and we are reviewing our business strategy based around inequalities and population health management, and working with our with the rest of the partnership and the system around that, to try and align it with everything that everybody else is doing. And make sure our business model fits that, and looking at what funding is available around that, and which funding is obviously coming to an end soon. The outbreaks in our bedded areas are causing lots of issues, because obviously that's preventing flow of patients being able to come out of hospital when we have to close our bedded areas because of COVID. So that is a big problem at the moment. We're going in and out of closures. Obviously then we can't put frail people into those empty beds. So that's a difficult one. And the other one is recruitment of home care workers, because we're competing obviously with them being able to go and work in Amazon and Costa and earn more money, and have that extra salary. Another difficulty that we've got is for people being able to access primary care GPs. Obviously they don't have enough of time, and that workload is increasing all of the time. And the lack of packages of care for people to remain in their own home is extremely difficult, and such a pressure at the moment that another reason why we can't keep people out of hospital. We are doing a lot of work around urgent care in the community to try and prevent frail elderly people and people who have fallen, and palliative care needs people going into A&E and having to be hospitalised. We're doing a lot of care around that, but there are difficulties in recruiting the practitioners that are required for those types of services at the moment, but we are all working together to try and improve that lot.
Thanks very much indeed, Jackie. I think that's just quite a good flavour of the pressures that are around at the moment. So thanks everybody for those contributions. So at that point, I think I will move on to the next item on the agenda, because as I say, that's given us a good flavour of what I think we all know. It's nice to hear it from the individuals concerned, involved in the different aspects of the system. So thank you. So we'll move now on to item 4, the Joint Strategic Needs Assessments. And I think building on what Andy was talking about earlier, and I know Laurie is of a similar mind in terms of, making the JSNA much more a living document and something that we can work with over the months to come. I'll hand over to Laurie, if that's okay, to lead on this item on the JSNA. Thank you.
That's great. Thank you very much, Councillor Owen. Yes, and I think the conversation that you've just had previously really nicely leads into the information that has been provided within the report. So I'll present the report through, and I will endeavour to answer any questions. And if Andy's still about and he wants to add anything on, then I'm sure he'll have the opportunity to at the end once I've presented. So as you're aware, the Joint Strategic Needs Assessment, or the JSNA, is a process that was established for local health and care needs to generate the evidence base for key local priorities, among other things, to inform and the development of the Joint Health and Wellbeing Strategy for East Riding. So in turn, this influences system planning and commissioning decisions to improve health and wellbeing outcomes across the East Riding. So the programme of work has been altered over the last 24 months to include the response to the COVID-19 pandemic, and this report also provides a breakdown of some of the emergency response work that was done as part of that through our health intelligence team, and some future considerations for the JSNA going forward, and some of the work the JSNA work that's been undertaken as well over the last 12 months outside of the pandemic. So we've got some recommendations as well that we're asking that the board note the progress of the JSNA priorities, and in particular the work that's been carried out in response to COVID-19. Review and agree the changes to the JSNA approach in light of the work post COVID-19 requirements, and in particular the new health and wellbeing system strategy. and associated intelligence requirements, and request partners' intelligence teams to actively engage in the providing of intelligence required for the joint health and wellbeing strategy and feature work that is outlined within the report there. So the apologies. So the joint strategic needs assessment has been a process that's been in place for some time now, and part of the 2021-22 needs taken has taken the challenging needs that have been caused by the pandemic into consideration as part of this. We've outlined some of the process that's been taking place previously as part of the joint strategic needs assessment process, and outlining how we would like to undertake the JSNA process going forward. In item 1.5, there's a table there that outlines some of the timescales and activities and events that we're presenting that would go forward as part of this new approach. So that would entail looking over the short term, accessing the intelligence position, including current data sources, intelligence networks that are in place, key analyst and network priorities, so that we affect the finding of knowing what we don't know. Then in the medium term, putting arrangements in place for the joint health and wellbeing strategy and priorities, undertaking roadshows, interactive events with system partners across the East Riding, and getting voices into the process. Then in the longer term will be the communication of priority and potential work plan for the JSNA system partners, and including the development of the JSNA intelligence network across the East Riding. So the intention is to keep what's useful from the current process and approach that's in place, and add the lessons that have been learned through the last 24 months and the information and intelligence sharing that's taken place during COVID-19. So we're learning from, COVID-19 and building and improving on the JSNA intelligence networks. So as we've outlined on numerous occasions, the JSNA should be recognised as a whole system process in assessing the needs of the local population. And to be more efficient, effective doing this, it needs to shift away from being a one team's responsibility and being a system-wide approach, with everybody and all partners being able to feed in to the process. And this will effectively fit better with the integrated care system and associated NHS intelligence systems that sit alongside that. The aim should be to build those collaborative networks, intelligence personnel across the area to share insight and information, and seek support from all the partners to enable this to happen. To be successful, the health and wellbeing requires the joint health and wellbeing influences across many parts of the council, the NHS, and partners, as we've touched on in the previous discussion. So there is an outline that the overall intention of the JSNA would be to give a real-time situation reports for the whole of the health and wellbeing system, outlining where the East Riding currently is in regard to the components that's shown there in the Dahlgren and Whitehead diagram, which shows the wider determinants of health, which our health intelligence team have also included some additional areas around that to modernise the diagram there. And this would change the joint strategic needs assessment and health and wellbeing approach from receiving a wide array of individual reports to stimulating and interlinking that cross-fertilisation of the wider determinants that I've outlined, which I think so Andy had outlined earlier on in the discussion. So the report there also summarises some of the work that's been taking place over the last financial year in 21-22. This includes work that's been going on, a considerable amount of work that's been going on around COVID-19, where the JSNA has acted as the backbone for regular questions and answer sessions for members, staff and partner agencies, and included media briefings on the current situation. The intelligence team also put in place regular SITREP reports that went out daily, weekly and monthly that gave accurate updates to where we were with case numbers, vaccination numbers, deaths and hospitalizations as well. the impacts of COVID-19 been long range. I know that we've been discussing some of them here, but the health intelligence team are currently working on a piece of work that will do the initial investigation on the impacts of COVID-19 pandemic on our local population. And this will be produced in 2022 and will play obviously a pivotal part in the interactive information collecting exercise over the next 3 months. Then we've obviously outlined a huge amount of the work and data that's been pulled together around life expectancy and the changes of that over the last 12 months. And further work has been done around population health and population health management. The partnership that's in place at the moment, we go through the business intelligence team, the public health intelligence team, and our NHS partners have been working on population health profiles. Apologies, I've got a plane flying overhead. Not sure if you can hear it, it can just distracting me there. But they've been working very closely with the primary care networks to ensure that there are health profiles in place that be able to detail their profiles for each of their populations, and working closer with our primary care networks then to support the prioritisation within the work that they're doing at the moment. Finally, we've just come through to how we're communicating regarding the Joint Strategic Needs Assessment. The Joint Strategic Needs Assessment documentation sits on our Intelligence Hub website, and this remains an integral part of the Intelligence Hub and is continually updated with both national and local data that we receive and produce ourselves. And this would continue, but we're also looking at the JSNA being communicated through proposed roadshows and being able to communicate this wider with the news of the Joint Health and Wellbeing Strategy. And we want this process to then be interactive, part of a conversation within there. So I suppose in summary, obviously looking to take what we've been doing with the Joint Strategic Needs Assessment previously and build on some of the learning that we've had through the COVID-19 pandemic and how intelligence has been shared much. The sharing of intelligence has been improved during that, and we'd like obviously the board to note that and review those changes that we're proposing and request obviously for that active engagement from partners as we move forward into the new approach for the Joint Strategic Needs Assessment.
Okay, thanks very much, Laurie. I think just for clarification, I think Shane's joined the call just in good time. Is it the Public Health Intelligence team that will be coordinating and pulling together all this information across the system from partners, etc.? And I'll also bring Andy in because he's had his hand up as well, but maybe between you can sort of answer that question, and I'll let Andy in as well. Andy.
Oh. Thank you, Chair. To try and answer your question, I think we need to think of the JSNA as not as a big book of facts that's produced once a year and produces a statement once a year that says what the needs are as a sort of snapshot. We tried that in the past, partially successful, but it's only a snapshot of that moment and often misses the nuances, particularly within communities and where information isn't gathered in numerate form. Often those values and those experiences are missed. So I think it needs to be more dynamic, and that's what we're trying to learn from COVID, in that when we brought people together, part of that was the data, part of that was the expressions of concern from senior managers and from stories, and they all came through together and give you more of a real-time picture of what was going on, rather than waiting on performance information to come through. And I think that's what we would like to move to, would be this, imagine a sit rep for the system, so that an ongoing, you could tap into something which would give you an idea of what the concerns are in the system, wherever that might be, whether that be workforce, whether that be outcomes, whether that be premature death, whether that be children not achieving things they can achieve. And that would be in one place. Now, it's not going to give you everything all the time, but what we can do is stimulate those networks, those existing networks, such as the Children's Trust Board or safeguarding or the NHS providers. What are their top concerns at that time? What is the intelligence they're using to make decisions? And then sort of enhance that intelligence. So by adding in bits of information, for example, from housing to do with health, so people not living in warmth in winter, what the impact does it have? what impact does that have upon education in children? And that's back to that system impact. So you're not looking at the lines of the operational plan with the performance and the outcome measures. It's much more what could be done across the system. So how could that child in that family's experience benefit them both in terms of immediate health, but also in terms of educational attainment and sort of community capital. And that different level of thinking, you need to bring together the different analysts. So they're not just reporting down the usual roads, they're going off-piste, bringing different bits of intelligence together, they're bringing different concepts and ideas together. And then that's creating the questions that create the strategic inquiry. So the board, the health and wellbeing strategy, the strategy being where are we now? We have a sit rep across the system. Where do we want to be? It's broader than we'll meet the operational plans. It's how can the system come together to improve for individuals? And then how are we getting there? It would have all these feedback loops. And the feedback loops would be the discussion with the networks. So what's the intelligence being used in the different networks? What's the overlap? How can it be brought together? How can it be improved by adding in these different flavors from different networks? So that's what we're trying to get to, is this more dynamic, interrelated intelligence network, rather than the existing well-trodden pathways we have now. So that's the shift. And I think COVID's really pushed us along in that. I'm sure Shane will say more, in that being able to get that real-time information, being able to talk to managers on the spot and say, what are your concerns? Then that then gives you the right questions to ask, which then generates the data, which then generates the actions to resolve it. So I think we have come a long way. COVID's taught us a lot, certainly in terms of sharing data. But the one thing we haven't really resolved is, I think there is a gap in intelligence across the system. I think we have great bits of data and we have fantastic analysts, but we don't bring it all together. And I think for years, the NHS have not been able to do it. The councils working with the NHS have tried, and it's not always worked as well as we'd like. And certainly we don't really understand communities in expressing the needs. We might pick up the usual voices, but quite often we don't pick up those hidden voices, particularly for the most marginalised groups who are probably going to suffer most out of COVID. And I think if we can build that into our JSNA, that's, if we are all about reducing inequalities, well, where are they? And who are we asking? And whose experience are we trying to address? And we haven't got that right yet. And I think that's what the next evolution of the JSNA is, to this broader sit rep, but with the ability to tune into those marginalised groups and find out what their experiences are, and then change the service. Inclusion health is something we want to talk about in the future. JSNA influencing the health and wellbeing strategy, but generally it's no longer the big book of facts. Although if you want them, there's tons on the website and you can search for anything you like. It's more about the intelligence and the insight, which then changes into action. And that sounds sort of pie in the sky, but we did it in COVID. We did it around care homes. We did it around hospital support. We did it around school support. And I think we know what works now. We've got the ability to influence and change things quickly. We just need to bring the intelligence together. At that point, Chair, if I could just hand over to Shane, because we've been talking to Shane for this for quite a while, and we've got some plans over the next few months in order to try and get there.
Can I just start by apologising for my lateness? I was having technical difficulties getting into the call, but I think building on what Andy has stated, obviously it's an ongoing conversation that we've been having about how to take that learning and translate it into our communities, and there are tools that I think we've invested in the system around structuring some of this insight that we're going to take forward and apply to that insight as we gather it from many of the networks that have really been built in that pandemic response by a whole range of organizations. And I think that will be the secret in terms of keeping the breadth of that insight as we go through this, to get that ready, actionable kind of dynamic picture of what is really, causing detriment to our population in whichever dimension they're suffering. So we definitely have a task on our hands to structure all this into something intelligible, just because of the volume. And I think we really will. It's exciting for me to be potentially knowing I'm going to be overwhelmed with the volume of insight to structure into a way that we can make into actionable intelligence. So I'll probably pause there, because I think there was some questions potentially.
Yeah, thanks very much, Shane. I'll come to Owen and then Caroline. So Owen next, thanks.
Yeah, thank you, Chair. And a risk of, in a sense, repeating what Andy has said, but just stepping back a minute, looking at the repositioning of the JSA as that kind of system intelligence, I think is going to be really helpful. I don't think historically some part of the system viewed it as their tool or any real reciprocal value for the intelligence they might provide. So, for example, we talked about education as a real determinant of health, and I think that's absolutely right. But our wider school community at the moment, and to get that engagement in the system, there has to be, I think, a real sense of reciprocal value. I think that the policy landscape is changing for us all, which will help. I learned this morning from the DFE that the SEND review will be published tomorrow or the next day, and that is going to, I think, fundamentally shift the kind of position of some of those kind of wider kind of health issues for children and young people across the education environment. So there's a real, I think, tangible reason for us to start the conversation with wider school community about, you know, why is their intelligence important? How does the JSNA as a kind of a real-time tool give them some insights? But what will be of greatest interest, I think, to the school community is how then the whole health and wellbeing system removes some of those barriers to learning collectively, and where the gaps in the blocks are, I think, is very much part of the kind of contingency of the Health and Wellbeing Board going forward. So I think there's lots of drivers that will encourage the repositioning that Andy has described and Shane has described. But I think we've got to work hard to kind of demonstrate that kind of reciprocal value at an early point, so it's not continued just to be perceived as a data bank for public health colleagues.
Thanks, Owen. And I'll come to Caroline now. Thanks.
Thank you. Excuse me. Thank you. It was just the point around the JSNA roadshow, really, in Appendix 3, which a lot of it seems to focus around what the impact of COVID's been, and whilst I absolutely appreciate that we need to look at that, I'm also getting increasingly concerned, and it's probably following the spring statement yesterday, with inflation running at between 7 and 9% and predicted to, with the fuel price increases, that we're going to see increasing levels of poverty, possibly food poverty, fuel poverty, income issues, etc. So it was just whether some of that could be teased out on the roadshow, because I don't really see that we've seen that actually land yet. But I think as we come into winter, then that could become a real, really significant issue.
No, fully appreciate what you're saying, Caroline. And it's, if we do have a roadshow, is it going to be in the right places, targeted at the right people? Yeah, absolutely. Andy, you want to come back? Yes, thanks on that.
Yeah, absolutely, Caroline. I think the goal of the roadshow isn't to present COVID facts or the impact of COVID's had on cardiology, etc. It's much more about that dialogue and what do people's concerns are they going to be, and it would be to express from birth right through to end of life the variation in outcomes and input. So that could be school attainment. It could be school absence. I mean, there's one that's probably very of particular interest at the moment, but that could run through to isolation. It could run through to unemployment. So it's that broad gamut of all in that Dolgan Whitehead model: employment, education, housing, variables across all of them, presenting them back out as part of the roadshow and saying there is a link to health and well-being. You can clearly see that, but what do you make of it? What are your chief concerns in Bridlington, in terms of, is it employment, is it social capital, is it access to health services, what is it? And then that prioritization exercise creates the debate, and the information fuels it, but at the same time hopefully we're getting experiences and information back, and part of it as well is to find out who those analysts are, who are the people you would talk to. Analyst not with a badge on, but someone who reads the situation, gives the sit rep to the people in that community or that organization, and then bringing them together. And then, so this ongoing dialogue. So it wouldn't be just a series of roadshows. It would be the start of a network, this intelligence network, which would then, we would pump in all those aspects. So not just COVID, COVID's in the report because we've done loads of work on it recently, but it would be employment, education, housing, environment, social capital, etc. All that would be in. That we've been looking at various information health indices and index, the various proxy measures you can use to work right across those variables. But at the same time, I think local insight is probably incredibly valuable in terms of that one person's life story showing all the variables, and then the service plan, but the service plan doesn't work. So I think it's a mixture of existing information we'll collect, and real life stories that shape the intelligence, which we would then bring back to the Health and Wellbeing Board. So hopefully in a few months' time, we will come back in terms of the timescale and say, these are the priorities, this is what people were talking about, and these are the gaps. And also these are the areas of inquiry where we need to dig deeper and find out more because there's an issue. So I think it's a mixture of generating the issues, intelligence, and it's not just COVID.
Thanks, Ali. Just before I bring Shane in, it's quite interesting. It's making me think of sort of discussions we've had earlier today about when we get government support for families having troubles in households, how we prioritise where to do it. Do we go for deprived areas, to give money? Well, literally, how do you prioritise and decide where to put things? I think this sort of work and data would really help it in making those decisions rather than sort of guessing at it with time. Yeah, thanks, Shane.
Thank you, Chair. It was just to add really to what Andy was saying there, really just on that we'll also be trying to gather the kind of the assets in those communities as part of that process as well. So actually where people have faced poverty, we've had obviously the furlough schemes and unemployment growing communities, and people will have come up with workarounds, and we've seen some of that through some of the schemes, particularly that Laurie kind of has commissioned out with customer services, etc. So we kind of have got some of how the communities have been resilient to some of that already in light of the pandemic, and we want to gather more of that, find out what is working, and so that actually we can hopefully resource more of that, and obviously where there are gaps in our communities to point teams at to help them build the things that they that their neighbouring community might well have developed that's kept them more resilient. So that was just a little bit to add there. Thank you.
Yeah, thanks very much indeed, Shane. Well, I think we've got certainly a change of approach moving forward, and quite an exciting one, I think, if it's done properly. And I welcome the input from everybody on that topic, and it's certainly going to be a different GSNA in the future and the way we used, I think. So thanks particularly to Andy, Laurie and Shane for giving an insight into that. We look forward to see how it progresses. So thanks very much indeed for that. We do have recommendations, which I will read out for anybody that's watching without any papers in front of them, which are that we note progress on the GSNA priorities, in particular the work carried out in response to COVID-19. Secondly, to review and agree the changes to the GSNA approach in light of the post-COVID-19 requirements, in particular the new health and wellbeing system, health and wellbeing world strategy and associated intelligence requirements. And thirdly, request and assist partner intelligence teams actively engage in providing the intelligence required for the new health and wellbeing strategy. This would feature both quantitative and qualitative data, as well as regular situation reports on system issues. If everybody is happy with those recommendations. Okay, thank you very much. So we will now move on to the final item on the agenda, which is an update on the pharmaceutical needs assessment. And I think Nikki will be there somewhere. Nikki Bush, are you there, Nikki? Thanks. Thanks.
Thank you very much, Councillor Owen. We're in a situation where I think we think that we might be a bit too soon going out to consultation, bearing in mind what's going on around us with the developments. We are very organised in that we are almost ready to go out anyway. It's a matter of holding the PNA rather than delaying it because it's not finished. It would sit better when we know more about the ICSs when they become into place. We know who we're consulting with. So just in summary, just to complement the GSNA, the PNA isn't like the GSNA because it doesn't change. It's published every 3 years. It's a statutory document that remains the responsibility of the Health and Wellbeing Board for now. However, it is an important document because it is integrated with the GSNA, And it does change in some way, because if, say, we needed to publish supplementary statements, they would be like the statutory amendments to it over time. So we want to try and make sure that the PNA is aligned with the JSNA appropriately. And given the fact that there's lots of strategy development and reviews going on, developments with the ICS, and the thoughts about going ahead with JSNA roadshows, we felt that we would be better placed just holding it and going out a little bit later, but we still have to publish by the 1st of October. So that cannot change. And the latest we can really go out is the 11th of July, which would mean the Health and Wellbeing Board would need to approve the document on the 7th. And the recommendation is that the Health and Wellbeing Board considers that option going forward, and whether the Health and Wellbeing Board feels that that would be a satisfactory approach, bearing in mind the ongoing developments. If anyone's got anything that they would like to sort of say. The PNA is used mainly by NHS England for market entry. So what it is a needs assessment that looks at whether the East Riding has any gaps in pharmaceutical services, which would mean that another body or pharmacy group could open a pharmacy and potentially destabilise the surrounding pharmacies. So the PNA is used for that purpose mainly, and it's also used by public health and what will be the new CCG, ICS, PCNs to actually commission services within their areas. So as I say, it has got a lot of information in it. It's got demography in it. It looks at whether there's sufficient choice of pharmacies for our residents. It's got insights into health burden within wards, plan developments, so where there's major buildings going up, whether there's going to be lots of populations going into areas that might need a demand for more services. And it also has maps relevant to the individual areas, the ward areas where the health services, pharmacies, GP out of hours, emergency care systems and things are placed. So we also look at pharmacies on the borders and health services on the borders, and it's a full assessment really, mainly at pharmaceutical level, as to in the East Riding, are we actually okay? Do we have any needs? Are there any gaps? And I've finished the assessment, and we still continue to have no gaps in pharmaceutical services, taking into account all the building developments and everything else that we've considered. So. Thanks.
My question was the other way around. By delaying anything, it doesn't prevent somebody that wants to open up a business from being able to.
No, because the existing, because we, on a statutory level, we don't have to publish till the 1st of October. We haven't got any we haven't got any changes in pharmaceutical services that have come up since the last board meeting. And the PNA that we have now is legally stands until the 1st of October. And the current PNA has no gaps. So we will not get any challenges with people wanting to open using any loopholes or anything, because the regulations have been changed legally to allow us that time. Well, nationally, all of us, all the health and wellbeing boards nationally have their documents published on the 1st of October.
Thanks, Nikki. Andy, you wanted to come in.
Thank you, Chair. I think Nikki's probably being a bit self-depreciating. I think we've probably got one of the best PNAs around and have had all the time Nikki's been running it. And what we were looking to do was get the timing right for this one, in terms of the consultation, when it's produced, who we ask, and getting it right for the ICS changes as well. So we wanted to ensure that it fits with what we're doing with the PNA roadshow, but also having ICS structures in place and the right people to talk to, etc. So it was a question of timing, and we did look at it in quite considerable conversations about what the timing would be, but we can get it within. Nikki reassures me, even though I completely trust her, but we can get it in for for October on this, and that we'll get the right people in, and we'll get it signed off by the right people as well. But it does offer opportunities to look at what pharmacies can offer, and again, COVID's shown us that pharmacies can do a lot more. So I think there's great opportunities out there, but not noting that it is a mammoth task to get it right, and the document is quite a substantial document, and it has all been done appropriately so far.
Can I just add that we did do a public survey as part of the PNA to get people's opinions on their pharmacies, and also get opinions of their pharmacies during the COVID time. And generally, people have been very, very supportive of their pharmacies. We've only had about 14% of people, low percentage of people that have got complaints about the way things have gone. But on the whole, people are very happy with how well they've been supported through the COVID pandemic by their pharmacies. I've got some good comments back. It's a very, very good survey. We had a good, looking at the postcode areas, we had good coverage right across the East Riding. So people came forward to tell us about their pharmacies from across the East Riding. That will be published in the PNA document. And Health Watch has also published something in their document that they've just published as well, haven't you? Do you want to add anything to that? Sorry. Don't want to steal thunder.
Yeah, thanks, Nikki. No, it's we have our intelligence report because we were involved with the questionnaire. We wanted to hear what the members of the public were saying about pharmacies. So we have now included all the comments, quotes really from everyone who sent surveys in our intelligence report, and that comes out monthly. So that goes to all partners. So hopefully each partner will have sight of that.
Thanks very much indeed. And just to echo Andy's comments, we don't underestimate the work that goes on in the background with all this, but it's one of those things where I know you only come to the fore every now and then, Nikki, but thanks for the work that's going on in the background. And at that point, if everybody's happy with the recommendations of holding the PNA 6-day consultation from 11th of July to 9th of September, thank you. And we've received the progress update with the proposed adjusted timeline. So thanks very much indeed for that. And at that point, I think I can close the meeting, but can I thank everybody for their attendance? It's going to be a really interesting few months ahead, I think, particularly as we see the ICS develop. And I take Claire's comments about various workshops. I think we will need quite a few awareness raising workshops moving forward on some of the things we've been discussing today. We'll take those on board, I'm sure. So thanks everybody for your attendance today. And at that point, I will definitely close the meeting.